Hello, Mobility Nation. Today, following up on all the information I've given you so far in cars, controlled articular rotations, irradiation, and some details about the shoulders and the hips. Now we're going to talk about the knees. And as we get through this 30-day challenge, I'm really looking for your feedback, and please start sharing stories of pain, injury, post-operation, but I'm mostly interested in chronic pain, and I'd like to help you out. I want to help you out, so share your stories and I'll help you out. And if you are continuing to improve upon the current pain that you have and to lessen it, it's good. I'm never interested, and neither should you be interested in temporary loss of pain. That doesn't mean anything. It's very temporary. It's some sort of trick that you are doing to your nervous system. So if you go to the chiropractor, you go to the massage therapist, you go to the osteopath, you go for reflexology, you go for acupuncture, whatever the therapy is, and you feel great for a couple hours later and then return to the normal state, that it doesn't matter then. It's only giving you temporary relief. You want to look at things that are going to give you permanent relief or reduce the volume of pain that you have. So instead of being at a 10, you're always bringing it down or managing your pain better, okay? So we are going to go with what we call the knee hinge. And I said that I would cover distal tendinopathy. So we had proximal tendinopathy up here in the hip, but of course we have attachments that go to this joint. So we have attachments that came to our hip, tendon attachments, and we have them in our knee from the hamstring and the quads. So before I start figuring out how to strengthen my hamstrings and quads and how to get them more flexible, I want to create some space in my knee, and you'd be surprised how much relationship is between the knee and the hip when it comes to back pain, and when it comes to the knee to the foot for foot pain. Something for us to discuss at a later time. So I'm going to take my left arm and feed it through like I'm doing a sleeper. And this is so I can mobilize that knee. So I'm going to do a couple different angles for you. So I say so a lot. I got to stop saying so. So dorsiflex, you need to dorsiflex and put the attention in the heel. And what we're going to do is move back and forth. So not with my ankle, that's my ankle. I'm going to turn it. And what you're going to see is that tibial bone actually shifts. See how I'm shifting the bone? This bone right here, the bone is going to shift. There's the shift, you see? That's what I'm looking for. And it's going to be more difficult, of course, as always, internally. That's where we need it, that internal rotation of the knee and then out. So that'll be one of your cars. And now we're going to knee hinge. So knee hinging, and some of you will not be flexible enough. Your hip and knee won't be there yet, and that's okay. I'll show you some variations. But what we want to do is do the cars in different areas of the tissue. So you might be so tight in the calf, in the hamstring, that you can't get that. So you just keep it wherever you can. Okay? But this is knee hinging. I'm working on my knee now. Okay? Working on the knee. Where do injuries come from? Usually in the eccentric angle. They come in the internal rotation. Because you have no room there. Where does pain come from? The pinch side. This is a knee hinge. Now just for strength, you could do some isometric tension. And then very slowly, with concentrated isometric tension, bring it down. Now, if you are having some difficulty to put your knee in a sleeper, You can do the same thing here. You can base your legs. You can hold yourself in whatever's comfortable, and without turning your hip, because remember, it's knee. That's why we hold the knee that way. So if you don't have that control, you'd have to learn how to do that first. Okay, so see how my hip doesn't turn, or my ankle isn't going back? It's my knee. I shift. See, I'm shifting this bone. I'm shifting that bone. Okay, you can hold it like this. That helps you. And then you start doing knee hinges. So I'm going to put this thought out to two of our members. One is Aaron Diedrichs is a strength and conditioning coach, and Lazar is a personal trainer with a lot of combat training experience, which helps them create nice programs. I'd like to hear your thoughts on when you approach strengthening the muscles, the muscle tissue. How much until now have you ever thought of the joint being an integral part of getting someone to become stronger? Then I have some really interesting stuff on neurology. I think I'm pretty confident it should blow your mind and add to your expertise when you're working with people, especially if they're hurt and they're coming to you to get strong. I'll leave you with that thought. Thanks for being a part of Mobility Nation. I'm here to help you. Don't hesitate. There's I think 10 or 12 of us in the group. I want to hear from you. I'm only hearing from a couple of you. Don't be shy. We're all learning. You might have information that I'm not familiar with. You may have a question that makes me seek the literature. I love reading the literature. And I'm here to do that work for you. I'm here to do the reading, okay? So please, ask the questions, because Mobility Nation will have the answer.